vive en Barcelona, ¿eh? Pero es que eso es un defecto, lo sabremos que tenemos español. ¿Qué le vamos a hacer? Y rápido también. This one. Ah, pero bueno, not that I know. No. Other. A bit.
Okay, no,
If you want to use it, but yeah. Just use the big board. Okay. 3 minutes. Yeah.
Almost jammed.
Esto no es, it's not connected. It's not working.
But no, sorry. Mine is working, it's also in there.
Mine is not getting.
Maybe the construction is, yeah. No?
No. No. Oh my god. No, it's not good. No. No consigo. No, no. No. Puede ser que no funcione.
¿El móvil está cargando?
Ahora sí, ahora sí, ahora sí, justo ahora sí. No sé qué has hecho, pero déjalo así, que fenomenal.
Enter.
I don't know if they can see the room already, so, so let's keep it quiet.
Not be that silent anymore later. I hope.
Are you going to be more observer or you want to participate actively?
I will participate if I think I can
Okay.
support. But the others are more important. Questions here if you want to see.
We start? Yeah? Okay. Yeah, okay. Good afternoon. Welcome to the second roundtable of PerMed, this year based on the situation of personalized medicine in Portugal and Spain. We will concentrate on explain today's success stories, challenges, and unmet needs around the implementation of personalized medicine. We have this type of roundtables every year. Last year it happened in Belgium, especially in the region of Flanders, and it was around talent and infrastructures of personalized medicine. For this year, the specific objectives are, of course, facilitating the dialogues among the different stakeholders, identifying the drivers and barriers of the implementation of personalized medicine, define concrete actions that we can support from the PerMed project perspective, also giving awareness around personalized medicine approaches and positioning the specificities of the regions, in this case, the southern of Europe, Portugal and Spain. So we'll have a very packed agenda starting now. We will start after the introductions with some keynotes explaining the current situation in Portugal and Spain, and then we'll go to the roundtable debate on the success stories, unmet needs and challenges. After a very short break, we'll go to a short presentation on what is exactly the project of the partnership on personalized medicine, PerMed. And then we'll discuss specifically from an example given by a startup on the topic, what is the experience from an innovator and entrepreneur in the area, and from there, what can we do from the perspective of the project to support the area in the next years. I'm sharing this QR code also for the audience online, so you can check with your mobile phone, and there's a couple of questions that we want to ask you to help also involve your opinion in the debate. You can see the QR in the following slides, so don't worry if I change a slide now, you can continue having it. I'll take now the chance to introduce the panel. So it's really an honor for me to introduce this number of experts that we have around the table here in presence in Valencia and online. So I'll start from the people near me, part of the project. So first of all is Dr. Wolfgang Wallensiffen from DLR, so the German Aerospace Agency. Wolfgang is the project manager of PerMed and is really an expert in policy advice and health topics related to funding at European level, and also representing the German Federal Ministry of Education and Research. He was also part of PerMed, and again, so welcome, Wolfgang. Also here on my left, I have Dr. Juan Riese from the Institute of Health in Aragon. Juan has an MBA and a further master's degree in Direction and Management of Research and Development in Health Sciences. He's a very experienced researcher in experimental oncology and was many years national contact point for the Health Framework Program and IMI in Spain, and also has a perspective of business management. And Juan is here also as Work Package 4 leader of the PerMed project, and especially in charge also of the collecting all the good practices that we have around personalized medicine. From the third, just as part of the consortium, I'll introduce myself. I'm Cristina Vescos. I'm Director of Innovation at EIT Health, and I have the honor to chair the session today. Also here around the table, we have Montse Davan from BioCat, so PhD in molecular biology, master degree on medical communication, diplomacy, international affairs, is director of strategic foresight and international relations at BioCat in Barcelona. And Montse is also the president of the Council of the European Bioregions and member of the board of directors of the European Cluster Alliance. So it's in many expert committees around government affairs in Catalonia, in Spain, and in Europe. On my right, we have also Dr. Raquel Cunha from CoLab Trials. He's a funding manager of CoLab Trials, a Portuguese private non-profit association specialized in supporting innovative health products through clinical validation and regulatory compliance. Raquel has also a PhD in bioengineering system from the MIT Portugal doctoral program and very experienced in clinical studies involving medical devices, in vitro diagnostics, and pharmaceuticals. Also, close to Raquel, we have Professor Carmen Ayuso, also head of the Department of Medical Genetics of the University Hospital Fundación Jiménez Díaz and scientific director of the Research Institute also at the Foundation, associate professor of the University Autónoma de Madrid, an advisor to the Ministry of Health in Spain for Genetics and Genomics Services, portfolio of national services. And Carmen, among many prizes, she has received last year the recognition of the Spanish National Research Award in Medicine and Health Sciences. So thank you for being here. Next is bringing a different perspective also from the industry. So I would like to introduce Cristina Nadal. Cristina is the Executive Director of Policy and Government Affairs at Merck Sharp and Dohme in Spain. And since 2023, she's also Vice President at the Spanish Association of Bioenterprise, ACBIO. Cristina has 15 years of experience in clinical practice, but also as professor at the University of Barcelona, and extensive experience in research in cancer biology and metastasis. Now, she has the head of the big private industry. But you can see it's an impressive curriculum from the scientists to policy and also private sector. Close to Cristina, we have Dr. Eva Colas. She's the head of the group of biomedical research and in gynecology at Vall d'Hebron Institute of Research in Barcelona, and since 2021 co-founder at MiMar Diagnostic and chief scientific officer of this startup, which is a pioneer in diagnostic in gynecology fluids. And on the other side of Cristina, you can also see Dr. Roque Oruezabal, Director of Innovation at the National Cancer Research Center in Madrid, CENIO, expert in innovation and technology transfer, especially in public-private partnership. He was a collaborator in strategic definition of the Andalusian Initiative for Advanced Therapy, and is an expert also on everything around regulatory framework for advanced therapies, as well as business environment. And then online, we can also enjoy the presence of Professor Josep Tabernero, who is the director of the Institute of Oncology at Vall d'Hebron and head of the Medical Oncology Department. I mean, the trajectory of Professor Tabernero is well known as the main key opinion leader in the area, impressive research career, chair of the Cancer Core Europe, and member of the board of directors of the Organization of European Cancer Institutes, and former president of the European Society of Medical Oncology, among many other positions. So welcome, Professor Tabernero. Also online, we will expect Professor Luis Costa from Hospital Santa Maria, University of Lisbon, Director of the Oncology Department, and Principal Investigator and Head of the Oncobiology Lab, Institute of Molecular Medicine in Lisbon. Dr. Vanessa Dorrey Ferreira, also online, is a strategic consultant on patient-public involvement and engagement, specializing in co-creation methodologies, expert in participatory research methods, patient-centered healthcare innovation, and patient organizational empowerment. Also online, we have Professor Astrid Boura Vicente from the National Health Institute, Dr. Ricardo George, senior researcher on biomedical sciences and public health, and in Lisbon, Portugal, and she heads the Department of Health Promotion and expert in human genomics. She represents the Ministry of Health of Portugal and is a member of the coordination group of the European 1+million genomes initiatives, and leads the working group on healthcare implementation. So she's the coordinator of the National Strategy on Genomics Medicine in Portugal. Also online, we have Dr. Joana Feijó. from Health Cluster Portugal, also bringing the private sector of Portugal, so specialized in business strategy, product development and commercialization in healthcare industry, with extensive experience in various companies. So now is the business development director at Health Cluster Portugal.
Recording in progress.
As also patient representative from Spain, we have the honor to have Dr. Julian Isla. He's an expert in software engineering and artificial intelligence, but also a patient representative, father of Sergio, a boy with Dravet syndrome. So Julian is the founder of Foundation 29, which is dedicated to support people with rare diseases, making precision medicine a reality. And Julian is also a member of the Committee of Orphan Medicine Products at IMA. And last but not least, we have Professor Ines Fronteira from NOVA National School of Public Health, so academic and public health professionals, with significant contribution on epidemiology, health policy, and global health. Is involved in many research projects, including tuberculosis, HIV, and vaccination. Member of the Scientific Advisory Board of the European Health Management Association and President of the Portuguese Association of Epidemiology, and advisor also to the Ministry of Health in Portugal, involved in the development on health policies, for example, during COVID pandemic. So, with this impressive panel, we are going to start. So I want to also, before we continue, thanks to everybody in the organization that you may not see, but we have a team on the back in charge of following this event. And I would like also to thank the people in PerMed that has supported this initiative. Medical Ego from EIT Health Scandinavia, Monica Frenzel from the French Research Agency, Malene Edmund from Innova, Kathleen Don and Jolene Rovers from Flanders, and many other support people also from DLR. And I would like to also mention specifically the institutions at EIT, at PerMed, who are from Portugal and Spain. So you can see PerMed, and will be explained later, it's a joint effort for more than 50 entities, but we have a significant representation from Portugal and Spain, from national and regional research agencies. So having said that, I would like just to give now the word to the first speaker, who is going to be Raquel Cunha, and who will explain us the situation of Portugal. So while we give the word to Raquel, maybe we can have a look at the overview in the survey of Slido, if we can see the profile of the audience that we will see, or we can show it afterwards if you want. Okay, let's go to the. Okay, so if people in the audience wants to join, you can do it, and we will see it there. But let's start and then with the presentation from Raquel. Thank you.
So good afternoon. Thank you very much for the invitation to be here presenting the overview of the Portuguese participation in personalized medicine. I'm Raquel, Cooperation and Funding Manager from Collab Trials. So in what concerns the personalized medicine funding programs, Portugal did not participate in ERA PerMed, but we are a participating country in EP PerMed. For this program, as Christina just showed, we have 3 funding organizations, together with the participation of the National Agency for Biomedical Research. The funding was maintained from the JTC 24 to 25, and with the results of the JTC 2024, we can see that Portugal was actually on the 9th position out of 24 countries in terms of number of projects of successful projects participating in this funding. Nevertheless, there is still room for improvement in what concerns the Portuguese participation, not only in the terms of the number of projects, but also as partner, but especially as coordinator. The majority of the Portuguese partners were actually academic partners, and we see that there is no participation of clinical and for-profit partners, as well as other partners with different expertise, for instance, regulatory science, health technology assessment, and value-based health. Therefore, there is the need to increase the diversity in partners, in the participation of partners with different expertises. Also, the main research activities have been detection diagnosis, as well as development of treatments, which is in line with the call topic that was launched last year, but also aligned with having more academic partners participating in the call. Thus, in order to have a more competitive EU and to improve the implementations, we also need to reinforce the evaluation of the treatments and therapeutic interventions in order to have a more successful implementation of personalized medicine in clinical practice. The highest focus was on cancer, which is aligned with the global results of JTC 24. And we should also promote the focus on other health categories. Since Portugal did not participate in ERA PerMed, the Portuguese partners actually looked for other funding opportunities, and those were mainly Horizon 2020 and Horizon Europe, especially the cluster health. And after doing a search on Cordis, the research resulted in projects. About 15% of the projects on the health sector with Portuguese partners were actually on personalized medicine, showing that there is an interest and also capacity in the field of personalized medicine. And Portugal was actually the coordinator in 14% of the projects. Still, there is potential to grow, but we are trying to show our capacity in the field. From these projects on the horizon, we can see here that there was a more diversity of partners covering so we have here more partners from the clinical side as well as private partners, but still a bit low on the numbers of clinical partners and also patient organizations. In what comes to the research activities, we have a more diverse and balanced research activities, and this is aligned with having the participation of clinical partners and also private partners pushing towards the evaluation of the treatments and pushing towards the implementation of these personalized medicine approaches in clinical practice. Despite having a bit more diversity, the highest focus is still on cancer. In what comes to the number of countries involved, we have 7 countries in the Horizon projects and consortiums of about 14 partners, which is a bit higher than the numbers for EP PerMed, but this is related to the call requirements. So it's expected to have these numbers. Nevertheless, in all the programs, what we see is the importance of the transnational collaboration between private and public partners. In terms of results from Horizon 2020, we see that we have been contributing to the publication of many papers, patents, also the publication of data sets, softwares, and so on. And more importantly, what we see is the development and the testing of models, platforms, prototypes, treatments, and therapeutic interventions, leading and paving the way for their implementation into clinical practice. Besides the Horizon and the EP PerMed projects, the Portuguese entities have also been involved in clinical trials. And after a search with the keywords personalized medicine and Portugal at clinicaltrials.gov, it resulted in 28 studies, with the earliest being in 2012. so this is a long time interest and capacity on the field of personalized medicine. And out of these 28, 10 studies were investigator-initiated, only in Portugal, and 18 were actually multi-country, multi-centric clinical studies, many of which were driven by the industry. As expected, their main research activity was the evaluation of treatments and therapeutic interventions. And actually here, cancer was actually not the number one health category, but still has an important role. In what comes to the initiatives in personalized medicine, we have an initiative from 3 universities that promoted a regional strategy for personalized medicine in the central region of Portugal. We have the Health Ministry of Portugal, as well as INSA, that is also on the online audience. They have been contributing and leading the strategy for genomic medicine in Portugal, the PerMed Gen. And basically the aim was to create infrastructures and processes for the adoption of personalized medicine in clinical practice, and also to contribute to the 1+ million genomes. INSA was also involved in many other projects, so the genomic data infrastructure, the creation of a genomic platform through the Can Heal project, as well as also focused on the prevention with the Prophet project. Health Cluster Portugal, that I saw is also on the online on the audience, has a project on the digital precision medicine, while the General Directorate for Health and ICIP are working on a national strategy to fight cancer, being one of the objectives, ensuring the access to personalized medicine by 2026. Also to share some examples of events from last year and also flagships and upcoming events with sessions on personalized medicine, just to give just a quick sense of the events. Finally, I would like to share with you an overview of the Portuguese stakeholders in the different categories and types of partners. And these ones are the ones that have participated both or on funded projects or on clinical trials. Nevertheless, there are much more partners willing to go forward for upcoming opportunities. In what regards lessons learned and key drivers for success, those include the inter and multidisciplinary collaborations between private and public partners, the engagement with the regulators and policymakers to ensure a successful implementation of the personalized medicine approaches in clinical practice, the inclusion of regulatory science, health technology assessment, and value-based health to have a focus more on investment and impact rather than the cost, having patient-centric approaches and engagement with citizens, as well as having cutting-edge technology is fundamental, taking advantage of the use of digital tools and AI to generate and analyze high quality and large-scale data, while ensuring the potential use for secondary use of data, following the FAIR principles and complying with the GDPR, as well as having highly qualified and motivated professionals is a success factor. On the other hand, the barriers and challenges have been the limited funding, still limited, although there was advances, there is still limited infrastructure across the country, resources, as well as limited number of professionals. We still lack a national strategy on personalized medicine that can be a comprehensive strategy aligned across EU, so across the different countries, to have a concerted implementation in the EU. We also have still complex regulatory requirements and ethical constraints, and we still have barriers related to the sustainability, scalability, and equitable access across the different EU countries. Fragmentation of the EU healthcare systems when thinking about scalability is also a challenge. And finally, the data integration and the interoperability between the systems and the wearables in order to obtain and have access to the data while complying with the data privacy issues. To finish, I would like to share an example from JTC24, the 3D Leukotab project, which aimed at the personalized treatment of patients with acute leukemia, with a Portuguese partner providing the social sciences and humanities perspective and having a key role on stakeholder engagement. So the key drivers for the success of this project are actually having multidisciplinary teams, sharing knowledge and resources, having cutting-edge technology such as multiomics, having advanced methods for data analysis such as machine learning, and also applying patient-centric approaches with the empowerment of patients and citizens. Thank you very much.
Thank you very much, Raquel. While Carmen takes the position to also explain us the situation in Spain, maybe we can open just for one comment on our online audience from the Portuguese experts. Do you want to comment anything or add any point to this exhaustive overview that we got from Raquel on the situation of personalized medicine research, implementation, and also overall policy approaches? Yes, please.
I can start. Just having some. I think that for us to have precise medicine, we need to have data. Data are the full of everything that we are speaking now. And here in Portugal, besides, we have different initiatives on collecting, structuring data. We lack a national strategy for data management and data governance. And in our view, these strategies should be a joint collaboration between the public and the private sector. Since we are not a big scale country, we have the right environment to do a very good implementation of data governance that then could be used for personalized medicine. And in my opinion, this is something that we need to think about here nationally. Thank you.
Thank you, Joanna. So we'll talk about data in the part of challenge. It's a very good point. Maybe just 1 minute, Astrid, if you want to comment also on this overview of Portugal from your side.
Yes, thank you. Good afternoon, everyone. And yes, Raquel, who I have not had the pleasure to meet yet, but would like to give a very interesting overview of what is ongoing in academy and also in partnerships in Portugal. I just want to correct one thing that I think is really, really important, and the rest we can discuss later. But we do have a national strategy for genomic medicine, and we've had before that a national strategy for personalized medicine, actually precision medicine. That was a shorter effort or a smaller effort, but was conducted by the Hospital Association. So that is also a very interesting document. The National Genomic Strategy is now in the Ministry of Health, so maybe it needs to go into public consultation, but we've had our issues with our governments falling, and so political issues, political turmoil in Portugal quite a bit, but it's an important, so if you want to, I don't know, then discuss this a little bit better, but I would like to make clear that we do have a national strategy for genomic medicine. It was a very big co-creation effort with a lot of stakeholders in Portugal, so I can go on about that, but I would like to make this clarification here.
Yeah. Thank you, Astrid, for the clarification. So we know that there is this national strategy on personalized medicine, and we'll talk exactly what is this policy level in both countries. So let's now give the word to Carmen Ayuso, who will present also in this very 10 minutes nutshell what is the overview of Spain in personalized medicine.
Thank you. Well, good afternoon to everybody. Good afternoon to those of you who are connected online. And thank you so much to the organizers for having invited me to this roundtable. During the next few minutes, I will address the overview of personalized medicine in Spain. And this is a summary of the points I will develop. Currently in Spain, we have 49 million of inhabitants. 7 of them are no Spanish of origin. And we have a system for the national health system which is distributed among the 17 autonomous communities. Let's say they have their own distributed national health system in terms of organization and budget. And regarding some questions that are related with personalized medicine, I will give you some figures. We have about 3 million of cases of rare diseases patients with the problems that they usually face, which are diagnostic delay, one of the most important. And we also have about 300,000 new cases of cancer every year in Spain, with an increased survival rate, which has doubled in the last 40 years. And regarding drugs-related problems or pharmacogenomics, 26% of Spanish people suffer drug adverse events in our system. Also, we have many initiatives related with personalized medicine in our country. I have chosen 2 main topics that have general implementation across Spain and are funded by Spanish government, the Ministries of Science and Health, and partially supported by European funding. The main programs related to personalized medicine in Spain are oriented to both translation research and public health. First, there is the transversal program of impact infrastructure with 3 pillars: impact cohort, which is related with Genome of Europe, impact data, which is related with GDI, and impact genomic, which is related with beyond 1 million genomes. And together with this, we have also about 60 projects related with personalized precision medicine, which are monographic on the topics, and which is related with the 5-piece plan and PERTE in Spain. And thank you. And we also have in the healthcare system a very ambitious and Spanish program, which is called GENES, which is the Genetic and Genomics Testing Portfolio and Catalog for the National Health System. And the related program, CGENES, which is an information system for the integration of genomic data at the National Health System. The main aims of impact, the 3 pillars of impact, are to establish and transfer knowledge and to support effective deployment of personalized medicine in our country, with an aim at the end for a more effective and safer preventive, diagnostic and therapeutic approach for every patient. As I said, there are 3 pillars: impact cohort, impact data, and impact genomics. Together, these 3 programs have a budget of about 25 million euros. And all of them are now in the second phase with another budget additional for the next years. The 60 personalized precision medicine projects which were developed during the last 4 years are dedicated to many different monographic topics, and together they had a budget of more than 150 million of euros. Regarding the impact cohort, these are the structure of this program. It's a prospective, multipurpose, and multicentric population-based cohort study who will integrate or recruit a total of 200,000 people, collecting data from very different sources, as psychological, social, environmental, biological, etc., to be followed by 20 years. All the autonomous communities in our country are involved, and 50 impact nodes, 59 research groups, and many associated entities. By now, there are more than 10,000 participants recruited. This program is in connection with the European genomes and will contribute with 2,000 Spanish people genomes. The other program within the impact infrastructure is Impact Genomics, which I have the honor to be the co-PI together with Ángel Carracedo. And this is a project which aims to implement and validate the new genomics, the new omics techniques with a very high profile of not only technology but also professionals, in order to solve several cases related with 3 topics: rare diseases, rare cancers, and pharmacogenomics. We have 2 different circuits, one related with the assistential or clinical care environment, and another related with the secondary use of data. There are also 3 sequencing centers, more than 100 hospitals involved, and all the autonomous communities are also involved in this project. We have obtained a diagnostic rate very high, taking into account that all these cases are undiagnosed cases, which have previously been studied with the routine care in our system. To be noticed, 27% of the cancer of unknown primary, we obtained actionable findings. And these results were obtained in a period of time of 18 days. We also have the results very interesting regarding the standardization of bioinformatic analysis tools, the procedures and processes related with diagnosis, and also the templates for laboratory and clinical reports. From the regulatory and ethical point of view, we also have a informed consent template for both clinical setting and also secondary use of the data. And we also obtain a territorial equity with a proportional number of cases integrating in this program according to the population of the different autonomous communities, and also documents related with MTA and DTA, and one important goal which was the governance politics for all this context. Regarding the clinical care of personalized medicine implementation, I'm showing you the GENES program, which is the Genetic and Genomics Testing Portfolio and Catalog in the National Health System, which aims to standardize National Health System genetic diagnosis, guaranteeing equity in access to all the Spanish territory, in order to have a care for patients with rare diseases and other genetic diseases as oncohematological disorders. We have 3 levels of complexity. Level 1 is comprising the areas, as for instance, ophthalmological, cardiovascular, or pharmacogenetic implementation. Level 2 is set by groups of diseases, for instance, ocular congenital malformation in the group of ophthalmological diseases. And level 3 is the specific diseases. We also have different aspects, very practical, which facilitate the implementation of this catalog and portfolio to the clinical practice, which is the type of gene test, the clinical utility, the type of sample, the genomic alteration that we can expect in a specific condition, and the type of techniques, and also the genes included in the different panels. This is publicly accessible in the website of the Ministry of Health. And as an example, despite it is one success story by itself, the impact or the genes programs, I can give you a very small example of one success story related with the undiagnosed rare diseases, which we have achieved very recently, studying more than 1,700 probants with this kind of conditions in the neurodevelopmental disorders, combining different types of omic studies and clinical data. We could obtain 34 cases newly diagnosed with de novo pathogenic variants in a kind of genes undiscovered previously, the non-coding spliceosomal small nuclear RNAs. And these conditions also have a biomarker very interesting, which is the episignature, which was also identified for this condition, and it's unique for this kind of conditions. And in conclusion, for this success story, we have an example of a new rare disease diagnosis strategy, which can be extended to many other cases in our system that will provide for this new finding. We have very similar key success factors and drivers as in the Portuguese case. We have developed programs at a national level, very well initially funded, with a robust organization and coordination between all the government structures. And also we have paved the way for solid regulatory and legal pillars, and also there were involved all the stakeholders. And in parallel with this, I didn't show you these results, but we have had very strong development of clinical research. But nowadays we have some worries about the new challenges and barriers, which is the non-stable and specific national strategy for the sustainability and the long-term funding of these programs, the digitalization and use of data according to the European Health Data Space, the implementation of data governance and regulatory framework. We have a very well designed data governance, but we need to implement in all the structure these suggestions and recommendations. More interaction with private agents, pharma, biotech, digital and artificial intelligence developers. And we need new professional profiles, the stable incorporation of specialists in genetics, which is a claim of all the professionals and patients that is in progress now in Spain, and also the training for healthcare professionals. And that's all. Thank you very much.
Thank you, Carmen. Also very impressive overview of the national research and implementation strategies in Spain. I would like to start now the debate, so open the floor to the full community here in the room and online, and we will start discussing. I mean, there have been already some hints from both presentations, and they seem quite similar on the level of the challenges that we need to confront for the personalized medicine. There is a list provided from PerMed that we can use as a basis for the discussion, so that there were selected of a number of identified challenges or barriers that we can discuss specifically for the areas of Spain and Portugal. So one of them was the regulatory and legal challenges. There has been some comments about it. Systemic challenges like access to innovative technologies, lack of national infrastructure, access to data, and so on. The third one is the knowledge and skills gaps. So that has also been discussing about the needs for technical skills, entrepreneurial skills, or translational healthcare capacity. The next one is the behavioral gaps, challenges, resistant to change, everything that is related to the conservative culture of the healthcare system and the lack of time for adopting new ideas. Next point is on the weak collaboration between different stakeholders at international, multidisciplinary, different levels. And the two last ones, one is the lack of knowledge of the personalized medicine benefits in general, so lack of awareness. And the last but not least, maybe there's a point that I'm sure is going to come in the debate, is the elements of investment and funding. So I'm going to open the floor to who wants to start the discussion on this part of challenges. If you can name specifically one important challenge that needs to be addressed on the implementation of personalized medicine. If this list helps you, or you can go with your own wording, go ahead. Otherwise, I take from my list of people. If we don't see any. Oh, here we have. So Astrid, maybe we can start with Professor Tabernero, that we have not heard from you before. Let's do that. Giuseppe.
Thank you very much, first of all, and thanks also to the presentations of Raquel and Carmen, because they have actually posed very well part of the challenges, but also opportunities that we have. And regarding the challenges, I think that although that we have robust infrastructures to promote precision medicine, I'm talking more about cancer, but I'm sure that in other areas this is the case. We are facing important challenges. Let's start, for example, with regulatory challenges, some of them related to the implementation of IVDR. And as you know, the implementation of IVDR has been really important. That was a need, but also it has delayed a little bit, some of the important aspects for diagnostics, especially in rare diseases, but also in the early stage of development, especially drug development, right? So this is one thing, regulation related to IVDR. Also, regulation related to the regulatory approval for drugs, or the reimbursing process for drugs for patients that suffer rare malignancies or rare diseases. Speaking about all kinds of diseases, I think that this is really important because, as mentioned before, we have a quite robust strategy in supporting the diagnosis of rare diseases, especially with all the genomic strategies that we have seen both in Portugal and Spain. But unfortunately, some of these patients, actually, when they are diagnosed of a particular genomic aberration, actually, there are not good paths to promote that these patients are treated with drugs already approved for other more frequent diseases, or even drugs that are in clinical development. I think that the limited reimbursement that we have for biomarker testing, because some of the efforts that have been shown today actually are under research projects, but not for conventional use. And for example, right now we know that NGS-based diagnostics in patients with cancer, in particular tumors, actually provide multiple opportunities for treatment, and this is not fully reimbursed across the country. Also, another challenge in our countries, both Portugal and Spain, is that the industry investment is limited compared to other countries. In particular areas, actually, this is not the case, but globally speaking, that is the case. And it has been mentioned as well, on top of the regulatory hurdles, we have limited physician training for precision medicine and limited clinical trial participation, globally speaking. We are obviously not talking about our institutions, but if we consider that, in a wide manner, we could say that there is limited clinical trial participation, and also the challenges of the knowledge that the different stakeholders have on precision medicine. Just to put an example of what others are doing, considering some of the challenges that I mentioned, I like, for example, the initiative initially led by the Dutch groups, the DRAP-like clinical trials. This is something that is being implemented in many countries across Europe. As far as I know, actually, Portugal is also piloting one of these platforms with a POP, but this is not the case of Spain, right? And this relates basically to the implementation of precision medicine once the patients have been diagnosed with drugs that are sometimes reutilized, drugs that have been approved for other indications but do not have the approval for a particular rare malignancy. And through these programs, actually, these patients can receive these very innovative drugs. This is an example of what we could do. Obviously, now the question was related to the challenges. Obviously, we could ask to EP PerMed support in different areas, but I think that this is something that we may discuss later on. Thank you.
Thank you. So so you identified that more than in research, there are really the challenges in the part of the implementation, especially on regulation, IVDR, and reimbursement pathways, and lack of really investment from the industrial side, and the need of physician training towards EP PerMed. So let's continue the discussion. I think the next one is Astrid.
Yes, so you already have a very comprehensive list of challenges, and I agree with all of them. I think one that has not been mentioned is political understanding, or understanding from the part of policymakers and political support. If we don't get that, then for implementation we'll be failing most frequently. Also in terms of investment, not exactly funding for research, but investment in infrastructures that are needed for personalized medicine. Related, for instance, to data management, which is really key, and governance of genomic data, and also the needs from the ethical and legal areas, particularly when legal issues are raised for personalized medicine and require sometimes legislation changes and so on. So I think one of the very, very important challenges is really to be able to talk about sufficiently about personalized medicine so that it does get to the ears and is followed by the understanding from policymakers in an ecosystem like health, where the competition is really with very important demands from patients and from hospitals that need services to implement personalized medicine, that if it keeps sounding like something in the future, then we will not get the sufficient investment that we need to really implement this properly. And then it all relies on really bottom-up initiatives. And that says it's really important to promote the study of economic models that will convince policymakers that this can be cost effective, or at least yes, cost effective. Certainly, from when we look at how effective personalized medicine can be for patient treatment and for prevention. So, and bringing up the word prevention is also something that needs to be talked about more, because prevention is one of the key aspects that can be improved with personalized medicine as well. So economic models and the study, a really deeper study of the health technology assessment, the health impact assessment of policies related to personalized medicine.
Thank you, Astrid. So it's sometimes we talk about political will, but you mentioned like one step before, in order to have political will, we need to ensure political awareness and understanding, and probably is where we are in this phase. So let's move to Julian. The floor is yours.
Thank you, Cristina. I'm going to be a little bit provocative and a little bit negative as well, because I don't think we are prepared for precision medicine because we are not prepared for medicine. My point is, we don't have data from our patients in a good scale to be able to create the models that we need for precision medicine. Let me give you an example. My son has a rare disease. For precision medicine will be needed the clinical record, especially long longitudinal data from our patients. We don't have it. And the other thing will be genetic and omics information, and we don't have it. I have the genome of myself, of my wife, from my son, and the genome is on my computer. I tried to use this genome for pharmacogenomics or for pharmacokinetics. No way. It's still in my computer. And that's the situation. The situation is nobody has a strategy with clear goals to implement precision medicine. We don't have it. We are living with the elephant in the room, where everybody is talking about these topics, but the reality is we don't have this strategy. Another example: how many patients, how many undiagnosed patients we have in Spain? We don't know. How many patients with the condition of my son we have in Spain? We don't know. And with these basics, we want to do precision medicine. I'm sorry for being so negative. The idea is also to be a little bit provocative, because I guess the idea of this meeting is really to move forward with these grounds. Thank you.
Thank you, Julian. So what you're saying is we cannot tackle what we don't know, and this is probably the first challenge that we have, and maybe we have strategies in paper, but they are not reaching the patients. So.
And one small thing, Cristina, is about the comments about reimbursement. Because reimbursement is it's an economical decision in most of the cases. And for this economical decision, another good example is we don't have the data. I have the opportunity to be involved in reimbursement discussion for one of the drugs for my son. And the question I was asking to the ministry and the committee responsible for this is, do you know the cost of the disease of my son for the system? No idea as well. So this is just one example, and sorry, Cristina, for interrupting you.
Thank you for the input. So let's go to also, I think it's interesting, these comments on the private sector. Maybe Joanna, you can bring some comments on that part.
So the comments that I would like to have here is something that I think we didn't speak until now. It is I don't know, and I don't believe that the healthcare professionals are fully prepared to integrate this medicine in their daily life. So, at least in Portugal, I believe that there is the need of a medical education program on this area, so they can understand how to use it, how to apply, and how to interpret genetic data. And I would like to rephrase what Julian said regarding data and the need of the integration of data from military and from medical records with genomic data. If we don't have that, we cannot apply precision medicine. And nowadays, here, at least in Portugal, we have some electronic medical records structure and with data with quality. but no integration with genomic data. So I think we need to do this first and then start implementing preventive medicine. Precision medicine, sorry.
Thank you, Joanna. So this data, it seems to be from all stakeholders' perspective, and also especially the integration, this longitudinal element. Let's continue with Roca here in the room.
Just following some highlights from Astrid regarding reimbursement, regarding HTA. I think that we already have examples in place of some areas in which pharmacoeconomics has been really important, and we have the case in advanced therapies. Advanced therapies started several products, ATMPs were authorized, and they failed. And they failed because they didn't have real pharmacoeconomic results behind supporting everything. And I think that pharmacogenomics has to be hand by hand with pharmacoeconomics, or we are able to show to the policymakers that the efforts really are working, or we are not going to do anything. So I think that investigation, researching in pharmacoeconomics must go hand by hand with pharmacogenomics.
Monse, you are the next. Yeah. Luis?
Sorry, I couldn't hear you. Good afternoon to everyone. Can you listen to me well?
Yes, very good.
Good. So first of all, I totally agree with what the previous speaker said about it, particularly José Tabernero. I just would like to stress one point that I think we have to tackle that. It's particularly in cancer. I mean, we have to have more precision medicine on earlier diagnosis. Not always about precision medicine on treatment, but we need more on the early diagnosis. And I mean, what is going to happen with cancer and the expenses with cancer, I don't know if we can support all the costs the way it is right now. So we really need to have a strategy to early diagnosis of cancer, and I think there is a role for precision medicine over there as well, particularly for people who have some genetic susceptibility that are larger unknown persons. Since there's not good database on that. We recently did an analysis about a mutation that is in Portugal. It's a foundational mutation in Portugal. And most of the cases we realized that people were not aware about that they had the mutation. The families were not called to analyze the presence of the mutation and to do preventive measures and even a preventive follow-up on those cases. I believe this could be also the case with other rare diseases, or I don't know if they will be so rare in other settings. But I think we need to also to have a strategy over there. And I don't know if you agree with me or not, but of course treatment is for those who have the disease, and we have to tackle that. And I totally agree with the access to NGS panels for those who really are important. I totally agree with the DRUP trials. I think DRUP trials will be a good answer for many patients. But I think we have also to expand our perspective to another field, which is the early diagnosis. And at least for many people do not know what they have to do to be capable to diagnose earlier a disease that can be curable.
Thank you, Luis. Monse, you were next.
Yes, thank you. I think we're touching upon some things that have already been said with the documents you mentioned about PerMed. And I was listening to Julian actually, and I kind of share his cautious approach when being too optimistic on where we are now. So, I mean, we can say that we have a strong landscape in Spain and Portugal, and probably it's not even. I mean, you have some aisles of excellence across both countries, but at the same time, they kind of drive excellence in Spain and Portugal in terms of generation of knowledge, technologies. So that is really in good shape. Now I'm less optimistic when it is about the manufacturing, the development, and we talk about ATMPs now, but when we talk about health data, even if, and Carmen mentioned the governance, but yet the governance has a lot of gaps to fill, and it's kind of complicated, and the silos of information that we have, and the use of data, etc. So this, I'm less optimistic there. And then I'm still less optimistic when it talks, when it's about, and we were discussing this before, is everybody, when there's the political commitment to personalized medicine across countries, is everybody aware of what it takes to be really prioritizing personalized medicine? It is about investment, it is about commercialization models, it is about investing on production facilities, it is about investing on how to proceed with the use of health data. And just a very small point about that. So reimbursement is an economic decision, but not only. Sometimes is a performance decision. So we need real world evidence also on what is going on with some of these developments that we are just bringing ahead. So I think that we need to be optimistic, cautious, and a little bit worried, so that makes us go further.
That's a combination of all of them. So I'm going to put maybe, Cristina, you on the spot, because there was a point raised related to the involvement of industry and the lack, specifically in these geographies, in the area of personalized medicine on research funding from the private sector. So can I throw this question or this comment to you?
Now you can hear me? Okay. So what I was planning to explain another thing, but because you've asked me directly to this, I would answer that the pharma sector is open to design projects, but I think that in the past few years, the sector and the National Health Services had used the pharma sector as a finance sector, like we want to do this, so you pay me for that. So that's not the way to go. I think we have to sit down, see which are our common interests or not, and see if we can find common projects. I think that's the way public-private collaboration really works. So it's not the way we have been practicing that in the past. That's my view. I'm not representative of the whole industries here, but I think I would focus on that. If you allow me, please, I would also say that I agree to many of the comments that already have been said regarding the barriers and the challenges, but I would specifically focus also on something that it's very clear to me, which is personalized or precision medicine is just a tool. I mean, why we do that? We do that because we want to improve the knowledge, the health outcomes for our society. We want to prevent diseases. In this way, we maybe are more sustainable or not, I don't know. At least we would have less burden of disease. And we want to boost also the do not do recommendations. So we don't want to harm our people. We want to be sustainable also in that way. So if we have these goals in mind, we should be, and I'm gonna give some support to Julian, because we are not very good in prioritizing what we want to do, why we do this. So that's the thing. So for example, we should do this or we should design projects based on the needs of the society. And we do projects, we do 10,000 projects. Maybe the whole of us wouldn't be enough to list of the projects that we have related to personalized medicine, but they are not clearly focused on the needs and the process that these needs have. So we should be very careful on designing or on defining these priorities, on defining KPIs, on monitoring these KPIs, on taking decisions depending on if we have fulfilled the outputs or not. And I think we are spending a lot of time talking about precision medicine and many things, but we're not focused on the needs. and our priorities and why we are doing this. So I think this is one of the barriers. And if I can add something very quickly on the key factors and the drivers, I have seen the presentation of Portugal and Spain. They are absolutely nice, but at the end it's kind of a list of ingredients that we have, and it's very important, but at the end it's important also the dynamics, why these ingredients mix and make the thing happen. And this is very related to incentives, which are different for all the stakeholders that are involved in this personalized medicine and stuff.
Thank you very much, Cristina. So in your case, we have very good ingredients, maybe, but we don't have yet the recipe to move this forward. So, and your comment also drives to advance a bit in the debate. So we want to talk also about the clinical needs, and maybe if I can give you the word, Carmen, also as a expert in the medical field. We've talked about prevention, we have talked about earlier diagnostic, we've talked about most efficient treatments, maybe better monitoring tools. From all these possibilities that personalized medicine brings, what do you think is should be the focus or the priority where we have to really focus for the next years?
Just my personal opinion, but I think the most important thing is prevention, which is based on the needs of population for a long term. So if we want to move to a real personalized medicine and different from the previous medicine, we have to change our paradigm. So we need to focus on prevention. But for that, and referring to the sentence of Julian Isla and all the audience, I think we have to center the needs. So we need to know much more about our population, about demographics, about the kind of diseases we have in our different populations, and to design a future focus on prevention. That's my personal point of view.
Thank you. I would like to also listen to many others in the medical field, if you agree with this clear statement, and that from Carmen to focus on the prevention side, maybe Professor Salamedes, and maybe
Absolutely. Obviously, even this is more important in cancer, right? Where we do think that doing very well. Actually, we could prevent 45% of diagnosis of cancer. Doing quite well, actually, that would be reduced at the level of 30%, right? But I think that this is extremely important. But even thinking on that, we have to acknowledge that 70% of the patients that could have cancer still will be diagnosed with cancer, right? So we need investment in early diagnosis. This is really extremely important. Treating patients when they have low tumor burden is more successful, without any doubt. And for that, actually, one of the topics, one of the points that have been mentioned before is what is related to data, to sharing the data. And I think that Julian made a very important point. But this is actually a situation that we face in all Europe, right? So obviously we have many projects that dedicate, including Portugal and Spain, to invest on accelerating genomics, implementation on genomics for diagnosis. Many of them actually are done through research project, right? And in here actually we have still many barriers that do not allow to provide a full implementation of that. And one of that, for example, is interpretation of the general data protection regulation. Still, we are discussing this, right? And obviously, this is a EU-based regulation that actually is very important. But at the end of the day, the level of implementation of GDPR correspond to the state members. In countries like ours, where we have decentralized regional health services, actually goes to the chairs of the regional health services. But moreover, at the end, it's becoming a decision of the CEOs, the managers of the hospital, how much flexible they are in facilitating data sharing, right? And I think that this is extremely important, something that should be, in my opinion, tackled at a higher level, a more centralized level, rather than the CEOs of the hospitals.
Sorry, it was the microphone was not on. Thank you, Seb. So let's continue with Astrid.
On that note, as well, it's not just the GDPR, but also the European Health Data Space, which will allow data sharing. There's a regulation there that will allow data sharing across Europe, but it's not really, it's partial when deciding whether genomic data is actually health data. It does say it is health data, but it has specific features and characteristics, obviously, that require a different approach. And the different approach is not well established in terms of legal and ethical questions that are raised and are not yet solved. So that's also one of the challenges, is to solve the ethical and legal challenges across Europe that are specific to sharing of genomic data. And without sharing this data really, for instance, for rare diseases and any rare cancers, it's very, very difficult to get solutions to the patients. So that is something that needs to be solved, and it needs to be solved, I think, at the European level, as the sharing of general health data has been, or is being solved through the regulation of the European Health Data Space. So I fully agree with Joseph that this needs to go further up and have decisions at a higher level than just hospital managers. Yeah, so I would really welcome a European solution for the sharing of genomic data, and I think it's in the works, but not. It's a lot more difficult. It seems to be a lot more difficult than it was expected to find a solution.
Yeah, it seems we have an agreement. Data is really a key challenge, but specifically for personalized medicine, is understanding the populations, the needs of the population, and as you say, the specifics of genomics and how to treat that across not only institutions, but regions and European level, especially for the case of rare disease, in order to have enough capacity for analysis. I want to bring maybe the conversation to you, Raquel, on this part of data sharing, compliance, legal, ethical. Do you see a hurdle there? Is that support needed? Very complicated pathway for many researchers to go through, no?
Yes, for sure. The regulatory constraints have been a huge struggle to innovators, to entrepreneurs, and also to the researchers from academic and clinical side. And basically, they do have ideas. They want to invest their time and efforts on developing new treatments and therapeutic interventions. But then when they face the regulation, most of their ideas just die in the Death Valley. So since it's too complex, it takes too long to actually get the approval of the treatments and therapeutics, that actually a lot of good ideas end up dying. That's also what some support that we do is on the regulatory science to make sure that they actually are able to comply with all the regulatory requirements and to go through the clinical validation in order to get to the market and to the implementation of these strategies in clinical practice. So we have been seeing that the innovators and entrepreneurs really face huge challenge, and also it's very costly to go through all these regulatory processes. So we see a huge challenge there that we need to cope. That's why one of our suggestions was actually to include regulatory science, but also the health technology assessment and the value-based health, in order to have this shift from from thinking about the costs of a personalized medicine strategy to think about, no, this is an investment and we are gaining quality of life, health, and we are actually reducing the costs of having actually the patients at a later stage of the disease without having much options.
Yes, and this is especially important when we want to focus on prevention, because that really requires new models for reimbursement and new economic models. Can I ask you a question before I give the word to Eva on her experience on this pathway of the innovation? We said we wanted to focus on prevention. From the analysis you've done on the clinical trials, how many of them are around prevention?
Actually, very limited ones. We don't have the numbers, although I have to give this note that this was the search with the keywords of personalized medicine. So for sure there is more clinical trials that we are not catching up because they are not related to this keyword, but prevention was very, very, very low.
On the things that we can research and probably not on the priority that we should be a bit more ambitious in that part. So just before we go to the last part on the success stories, I would like just to give the word to Eva on this part of the experience from a researcher and innovator on the challenges of this pathway and the Death Valley that we've mentioned, especially related to regulatory IVDR and other regulations. Yeah.
Thanks. So I was just like called by the attention. So when I was hearing everyone talking, I was like, well, but this is just talking about what happens when you have already like the innovation and you want to implement it in the healthcare. So obviously there are all these constraints that we should face. I think that we have something in the very, very beginning, where that is like innovations. Most of innovations will start in the public research groups or in the, I don't know, academic or non-academic research groups, let's say. But then the people that is there is scientists, and they don't know anything about entrepreneurship. I mean, we are not skilled for, I mean, we have to get training in accountancy, even if we haven't done any accountancy, when we lead a group in human resources, because we have to deal with all the people in the group, and then in science, that is obviously our profession. But then to become entrepreneur has to get some attitude, which is very important, together with the skills. And I think that in here we are not trained for that. So we really don't know what we face when we start this path of being an entrepreneur, even if we can hear that you need a regulatory or a quality system or like things that of things that are implemented. But how to reach that is a lot of formation and a lot of time. And I think we need to get oriented or at least trained. Most probably we are not able to do it by ourselves. We need to move this outside academia, because I mean, I truly believe that there are very few innovations that might end up into the clinics just by following the academic path, because we need a lot of funding to reach that, and we need to cover a lot of specialties that is not the ones of our research group. So quality, regulatory, HTAs, reimbursement, understanding. So this is already a lot of different specialties. So I think that in here there is a big Death Valley, also like for protection, for instance. So most of at least the institutions that I know, they don't cover national phases, which is a huge expenditure for our research group. And then, so this needs private funding in most of cases. So so there is this first Death Valley in terms of resources and know-how or knowledge that someone should need in order for doing this implementation, and we need to orient or to activate this attitude into the researchers so that they have to think that, you have to at some point think, is this research that I'm doing just research, or this research is having to head through a product to be implemented. And if you does this, I mean, you really have to turn your head and start thinking about what do you have to activate. If it's a license, if it's a creation of a startup, and construct all this, which we don't know anything about. So a lot of knowledge behind. Yeah. So I think we have covered mainly three big areas. One is about the data infrastructure and so on. One is about more the policy level, regulatory and elements for facilitating that process. And the third one is related to talent and skill gaps that are required to definitely go through the innovation pathway. Let's, finish this first debate with the examples of good practices. So I want to finish with some good examples that you consider. You have mentioned some of them, but why you think of these examples, that why they are good practices, and how can we learn from it to replicate in other areas? Maybe I can give the word to you, Roque. You mentioned the national pharmacogenetics implementation. Why you think this is a good practice and at this national level of political implementation, and what can we learn from it?
Well, at the end, I think that some things that seem to be a problem sometimes can be also an answer, and I think that's also the situation in the case of Spain with the 17 autonomous regions. The 17 autonomous regions have done different things, and Carmen has shown perfectly several of the things that have been doing. And at the same time, they are, I would say, something like an environment of practices. And you can check which autonomous regions have done several things and what have done others, and what has gone better than in each case. And I think that that's good. And at the end, once you have all these options and all these opportunities among all these autonomous regions, you realize that okay, you have as country, you have to make some kind of harmonization, some kind of standardization, because at the end is the same Spanish public healthcare system. So at the end, I think that to start with a catalog with a clinical genomic portfolio, I think that it's a good idea, because at the end involves all the autonomous regions, and it involves all the autonomous regions in the same effort. So I think that that kind of boost from the health ministry and from the Instituto Carlos III are good for the pharmacogenomic area.
And it can ensure, equity in the access to the treatments in the population. We have also some other good practices. You can raise a hand if you have others. I checked from the previous information that you have provided. So Julian, I'm going to give you the word now to say something good, if possible, related to the examples you mentioned about the UNICAS and the diagnostic GPT. Maybe you can explain us why you have considered those as good practices.
Thank you, Cristina. Yes, absolutely. We have good examples for being much more positive. UNICAS is one idea that right now is being real, because the head of the hospital San Joan de Déu in Barcelona called me during the pandemic, and he talked to me about why we are not creating a comprehensive set of services for patients with rare diseases. And we come up with the idea of UNICAS, which right now is a common data platform for patients with rare diseases in Spain. This is an ongoing project that we are building under the umbrella of the Ministry of Health and in coordination with the 70 regional healthcare systems. And it's a very good example, because we are building from the ground the infrastructure needed to provide a good medicine for patients living with a rare disease. Right now, we are building the common grounds for the data platform and also the application that the physicians will use in order to provide a consistent approach in the clinical practice. On top of this, the project will have services on top of the data platform. The services, for example, will be precision diagnosis in the future and other tools. As part of this strategy, we explore how AI, artificial intelligence, can support diagnosis of rare diseases. And we have a very good example of adoption, which is the XGPT. The XGPT is a tool that we created in Foundation 29 almost 2 years ago. And we had a very incredible success landing the tool in the Madrid healthcare system. Right now, all the in primary care, they are running our tool. And something I learned is not about the tools, it's about the process. Our big success was to make sure the tool was part of the process. And right now, when the physicians they realize that a patient could have a rare disease, they can start the process of and convert diagnosis in secondary care. And we managed to implement the solution in 3 or 4 months. I guess this has been the faster implementation of a technical solution in a public healthcare system. And right now we are doing the same thing in Barcelona, in Catalonia, in all the area. In Barcelona, we are targeting secondary care, I mean hospitals, because the diagnosis of this condition usually is in secondary care. And if everything is okay, the learnings from the project will feed UNICAS in the future, in 2 or 3 years, in order to have this comprehensive approach for rare diseases care. Thank you.
Thank you, Julian. These are really excellent initiatives, also brought from patient initiative, but really adopted by the system. And I have to tell you that UNICAS is not only considered a good practice from yourself. The other day at the Mobile World Congress, the Secretary of Digital Health was putting this as an example of really sharing data across hospitals. So,
and I have to say a big thank you to Juan Fernando Muñoz, because he has been really the key element to make sure the idea was materialized in a concrete example. We used funds from the European Union in order to land this project, and Juan Fernando was the critical element to materialize this idea in something specific.
No, it's a project that has really reached a capacity of political influence and then scalability. Very good. Then coming from this patient perspective, maybe Vanessa, I can go to you on this. Do you have any other good practice on how to involve patients in this part of personalized medicine that we can consider also a good or best practice? I think we don't have Vanessa at the moment, so I'll continue then. Anybody else wants to mention a good practice? Maybe Montse, go ahead.
Yeah, thank you. So I was looking at some figures. For example, if we see where are the main developers, for example, we talk about ATMPs. Globally, you see that it's 20% in Europe and about almost 50% in the US. That was 2024. Let's see what happens, but anyway. So for me, a good practice would be having a lot of developers on the floor and on the ground and producing ATMPs and easing the costs of arriving those ATMPs to the public, to the patients. In Europe, 1 out of 3 are in the UK. So for me, a good practice is everything that accelerates the arrival of these solutions to the patients. And then we have to see the different systems that you can use to accelerate these ATMPs, from the lead compound, seeing the efficacy, helping them with the patient. That goes very much in line with what you were saying. Also the markers that you can use, the scale up, all that are good. I mean, any accelerator that is acting on that level is a good practice. We are putting in place one in our region, but there are many for sure. also that you need data for that, so you need to have the data available for these evidences, for these real-world data, and you need to be prepared to store it good quality. So, and you need talent. So when you try to accelerate that, anything that you do on that line is a good practice. That's from my perspective. And then that is one of the ideas, the accelerator. Any type of accelerator can be a good practice because it fits the purpose. But then also we have an example of the Observatory for AI and the program Health AI. So we identify, it's about 170 tools that are being developed on the AI field to support the healthcare decision, the image, etc. And this is very well connected to the health ministry and supporting the adoption of those technologies for the healthcare. That is one good practice, and it's the observatory.
And then also the third one probably is one that is in the Precision Oncology Master Plan in Catalonia, and I'm talking about my region. You have this OMIC-HES project that intends to integrate all types of data, genomic and also clinical data for decision making. And it is a very good example of public and private partnerships. So for me, another good practice is everything that connects public and private funding, because we need this investment. And there's Microsoft and Fujitsu supporting this public initiative. So these are the three levels of good practices I would share. It's very interesting, this practice that you mentioned with the public-private collaboration, because I think, as Christina has mentioned, these are not, I mean, it's a different role for industry. It's another partner at the table with a similar level of capacity of decision, and the rules of the game are more participatory for industry. I think we have another example of good practice from Luis, if you want, and then we will close for the.
Thank you. If you allow, I'll take just 1 minute and a half. I would like just to share one experience that happened with us with the ELT4 program, where we were involved with together with Spain, Sweden, and Estonia for polygenic risk score for human without the diagnosis of breast cancer, but want to know if they have a high risk polygenic risk score and they should change their program of breast cancer screening. Why I mentioned that? What happened is that we opened the call for by the hospital regular communication to the exterior, and in 2 or 3 months we got 800 women wanting to participate. You have to stop it. So the society is very much aware about anything that tells you prevention or early diagnosis. They want to avoid the problem. And this was a big learning for myself, because we are in our clinical research center doing a lot of trying to do an increase in the number of trials in breast cancer and other tumors to treat disease. But I was surprised with the adherence for the common society to participate in anything that could be, early diagnosis or knowing your risk and trying to do something for your future. And I think this was, of course, for us, an example of partnership with Spain and Sweden and Estonia, and was a learning process for us. The second one is that we are thinking more and more and working more and more in the Iberia concept. Okay, we have 2 countries, but it's Iberia concept. So we are trying to do more and more connections with some centers in Spain. Of course, in many of the cases, they have more experience, more power, but we also can contribute with something, and we are trying to do more and more this kind of concept. And this is being very well accepted by the young doctors, by the young players. And that's, I think, is something we should be, emphasizing more and more, because we need to be together in a world that is becoming much more complicated. We need to be together for many of the things in the future.
Thank you, Luis. Definitely, I mean, the practices that you have mentioned, they all involve collaboration of different type of stakeholders, and this capacity specifically also of patients and clinician involvements, and also, as you say, public-private collaborations, and with a capacity to detect data or collect data in a structural way that really can help to inform decisions. So I think from the different examples, they are from different areas, but all of them have these characteristics that we have mentioned also in the challenges and in the needs. So I think with this we can break the first part of the debate. We are a bit late compared to our schedule, so maybe we can start again at 5 to 4. We will join here to continue the session for the second part of the debate. Thank you. So, good afternoon. We are back again, and after this first half of the session was more state-of-the-art situation analysis, we are going to focus this second part of the discussion really into action. So we'll start with, again, two presentations, first from Wolfman related to PerMed, and then a concrete case study of me, Mark, from Eva. So Wolfman, the floor is yours.
Thank you. I have to apologize because some of the people in the room will maybe have seen some of the slides already, but it doesn't matter. And I also would like to have one very short comment. I really had to work hard on myself not to say too many things just before, because I just have a déjà vu of 13 years discussing on personalized medicine, and all of these things kind of come in circles back again. Luckily, I have the feeling that some of these circles have been cut, and we are quite successful when it comes to personalized medicine. At least PerMed, the European Partnership for Personalized Medicine, is trying to support. With, in total, a lot of budget, but in the end, if you look at clinical trials and things like that, which we don't fund, maybe not that much. Anyway. So, first of all, the vision of European Partnership for Personalized Medicine is to improve health outcomes within sustainable, and we talked about that already before, healthcare systems through research, development, innovation, and implementation of personalized medicine approaches for the benefit of the patients, citizens, and societies, or society, which is the big vision. Nevertheless, I think over the last 10 years, a lot of things happened already. And I would say that actually the personalized medicine concept, and I agree there, I think somebody of you said that as well, it's a concept. It's actually using all medical information, personal health information, life information, whatever, and all the technologies which we have and can use to get the best out of it for diagnosis, treatment, and prevention. So that's the thing, and it actually doesn't matter how you call it, precision medicine, P4, I think nobody's telling that anymore, but that was also a name for it, or stratified medicine, depending. And the last point before I completely start is I think you have two perspectives. You can have the perspective from the comment we had in the last session, when you really come from one person having a certain disease which is really tricky, and rare diseases usually are tricky because they're on a genetic basis and they are usually a very strong challenge for the person, a big threat. So that's extremely personal. On the other hand, we come from big blockbusters like antibiotics, which are really interesting for not only the people who are cured, and we are still happy that we have them. They are under threat, but hopefully that's not that quick. But on the other hand, there's industry and they want to make profit, and that's nothing wrong with that. But then we have to find a balance between profit, possibilities, medical needs, and again, the healthcare system, the sustainable healthcare system. There's a lot of budget, especially in Germany, but you have to use it in a proper way, and there's lots of needs, and you have to do the decision how you use this. So I stop here. This was just my prelude. Okay, so we here have a short overview. That's the European Partnership. It's a co-funded partnership, which makes it with a lot of budget, but very complex. Co-funded means that at the moment 60 partners put in own budget, because 85 and almost 90% of the 60 partners are funding organizations and ministries, so they put in own budget, which is far more than we get from the Commission. So we have 275 million from the partners at the moment dedicated to calls and other activities, and approximately 100 million from the European Union for 10 years. 1 year is already gone. And this 100 million, also for your explanation, we still have to earn, because the partners have to put budget into the calls in cash, and then that is kind of, in the end, when we spend all that money, we get the 100 million for sure. So this is a stepwise process. 7 years of implementation, that means 7 years of different type of calls. I will explain a bit about that later. And we call it now 3 years of transition phase. So that is the last projects which are funded within the partnership have to be finished. they need 3 years, but also we prepare hopefully a second phase or whatever's coming afterwards, we don't know. There might be nothing coming up like partnerships anymore. There might be other things like agencies or institutions on European level. Anyway, and at the bottom you have some ways of either getting information or contact. So again, here I don't think I have to explain that too much. It's about readiness levels. We call them not only technology readiness, but we also call them care readiness, business readiness, clinical readiness. So there's a different approach to this. The major 3 steps, I would say, for personalized medicine, but for most medical approaches, is actually research first, then the innovation steps, and you mentioned some things, and you will mention more, I'm sure. And even more complex is the implementation, because also in the 2 countries we are dealing with today, Spain and Portugal, the health systems are completely different. So this is all over Europe and worldwide as well. You have a national health care system like in the UK. This is the more or less simplest way. In Germany, you have a very complex thing with the private insurances and the public insurances. In Spain, if I did understand that right, you have the regional authorities taking care of that. That gives some flexibility, and I think that's very interesting. So that's the point. So that is actually also the reason why we have the logo like it is. So that's the Möbius band. So the way of innovation is not going from research over innovation to implementation, but it's also going backwards. So this is kind of an endless circle for improvement, which we hope. And to make it also simple here, 10 minutes for a European partnership is almost nothing, so I talk so quick as well. So what we are planning is, and here I concentrate only on the calls. So we have 2 different types, several different types of calls. But in general, we have 2 different strategies. One are the so-called co-funded calls. As I mentioned, there's in-cash by the partners deciding on the topic if they join or not. And then there will be a top-up funding from the EC share we have for EP PerMed. Usually that's approximately 5 million, but that depends on how big the budget from the national partners is. And that's actually national partners on national and on regional level. This is these kind of classical joint transnational calls, and you always have to have at least 3 countries involved and so on. It's a bit similar like the Commission calls as well. And then we have the second type of call, which is called also a co-funded call, which is called Research Innovation Technology calls. This one is under preparation, I would say. And the idea is to get a bit further from the research arena into the innovation steps. Again, I cannot say that much more because it's still under development, but also here, the interested partners getting in with in-cash budget, and there will be some top-up funding from our money from the Commission. So this is it. So then we have in the research arena in blue, that's why I put also the colors here, again like in the logo, there's also the so-called networking support calls. There's a pre-announcement on the website, so that's about networking in the research arena, let's call it this way. But they are funded fully with EC budget from the EP PerMed. Then we have in the innovation arena, we have the fast track call and the venture creator call. There are 2 different types of calls. One, the fast track is actually supporting for half-a-year projects which kind of move towards the startup and something like that, more in this way. Very much inspired by EIT Health activities. And they are actually taking care of this one. And as well on the venture creator, that's more something like move it in 1 or 2 TRL or RL levels up, and you get support from mentors. That's the easy thing about it. So they are not grants, okay? Then we are also planning in this implementation arena or implementation step, we are planning twinning calls. Again, they are still under preparation, but in general, the concept is that, let's say, in Catalonia, they have a really nice concept at the Val de Hebron for personalized medicine, and then they offer this as a kind of donor for best practice example, and then there will be others coming, either 1 or several. We haven't decided that yet. Whether in 1 step or in 2, we haven't decided that, but in general, And then they take this on board, either on a regional or on even on a local level, as a hospital to hospital. We see how this is going. Because the thing is, everybody is talking about data, big things and research, but we really need to get these things via the innovation to the patient. And I think that's the really tricky bit. I mean, I would say you lose from 250 projects or good achievements in research, you lose at least 200 when it comes to the innovation, for a lot of reasons. And they're good reasons. They have even good publications, but they don't succeed. Sometimes you cannot do this. If you go in a setting for a private setting, you cannot even understand how they did get the results. And I'm provocative here as well. So then you lose another at least 40, if more, when it comes to the clinical trials, to all the approvals, to the regulatory approval and so on. And that costs a lot of money to industry, so no industry bashing here. But that's the thing. And we need to, in the end, and that was also a question which was asked before, I would be extremely happy if after the first 5 years of EP PerMed, we have 5 approaches, PM approaches established, either from the research or via these tools into clinical practice. I would be happy. Really. I mean, you all know that if you have a good idea, you do the research, it takes 10 to 15 years that you get it to the patient. Okay. So then we have, that's clinical, and then we have also planned something like education call, that was mentioned before. So we tackle already a couple of things you mentioned. The idea is actually that we kind of define a certain target group, and then we support them in getting an understanding of personalized medicine and listen to their needs. So it looks as if at the moment the first target group will be providers. I think, again, that's why it's in the implementation part of this whole setting. So I hope I haven't missed my... Anyway, so I skipped this one and just like shock you with that one. Again, the colors are in line with the logo. So all in green is implementation, all in yellow is innovation, all in blue is research. And then the research is kind of divided in technology, preclinical, clinical research. I think that's pretty common. Innovation, we haven't divided, but we could. Anyway, and then the implementation, and an extra thing is actually the patient-citizen engagement. And you just see from the 5 work packages, you can forget the first one, which is coordination and management, but almost all the other work packages support activities or efforts, let's say it this way, in all of these. And on the left and the right side in the white boxes, and we will share these slides with you, so don't worry, we kind of very briefly explained what we are planning to do over the 7 years at least, some of them over the 10 years. So that's the idea. We have these big so-called joint transnational calls every year. We will have network support calls, matchmaking events. I haven't talked about that. That's the other thing I think I hope is very promising, hopefully, that we have not only specific small matchmaking or partnering events or tools, but we should have, hopefully next year, a big event, so that whoever comes from the research arena with their projects successfully done, with lots of achievements, we hope we get from the private sector, it doesn't matter, startup, SME, industry, joining there, and maybe also we have good contacts with EMA, but maybe also from some national level regulators and HTA and so on. We invite them all into one big conference, and then part of that, that's at least my idea, we have to see, I'm not deciding on my own, but we have then something like a fair, so that they can speak to multiple. So it's not only one. That's another problem, because you have a research group or project, and then they have really achievements, and then they choose one industry partner potential, and then if this is not working, the marriage, it's broken. And then if the people move on in their career or get retired, it's completely forgotten about it. This is really bad. And there needs to be some competition. I mean, the private sector, I don't have to explain that. Vice versa, I think that's important. It's an offer. I mean, you cannot force anyone, so that's the idea. Okay, but then we have the venture the expand events. We have summer schools on the level of innovation. There will be a summer school in Palermo this summer in June. where we really try to get early career and other people knowledge about what is a business plan and so on and so on. We have something similar in Zaragoza in November. It's not yet published, it's under preparation on the level of research implementation into the healthcare system. So there's a lot of things going on. We have already had one in situ visit, meaning that we visit, in this case in Stockholm, the Gene Center, and they gave a really nice presentation from research up to implementation, and patients were there as well. The next one will be in Prague, connected to another conference which is dedicated to look backwards, because two other things very important. There has been a strategic research and innovation agenda in 2015, and I would say more than 50% is still valid, data for example. There has been a recent SRIA, which is part of the development of a partnership in 2023 in June published. So there's a lot of the things you said already in there. So if you need some arguments for your discussions, you can take them on board. So there will be an update of the SRIA. We promised it by 2027. You're all welcome and to support us there if you have the time and would like to. Then we will have also best practice examples. We have a call for survey, but stop it here. And that's the last thing now. We have 3 advisory boards, one on innovation, one on implementation, and one on people engagement. Have I time?
Good.
Well, we'll stop here. I wanted to say something about patient organization. That's the really last thing. In the JTCs, from this JTC on, we offer the patient organizations that they join a consortium proposal, and that EP PerMed with EC budget is supporting them. And that was with the first call, that's the second one where we started that, a huge success. I didn't expect it like that. Some of them even say, okay, the 50,000 for 3 years is not enough for us. We put our own budget in kind, some own budget in kind into the project. So there is something very crucial. You have the patients already in the planning phase of a research project or consortium, and they should continue then until the end. So I really hope, and that's my very last point, when we discussed this before, do not underestimate the people and the patients. If they really know about something which can help them, they put pressure on the policy, and believe me, it's working. So sorry, that was right in 10 minutes. I could talk one day. Thank you.
So thank you, Wolfman. We are going to go with one concrete example of the innovator journey guided from Eva and Mimark, and then we'll start the discussion. So Eva, the floor is yours.
Let me put the mic. Okay. Yeah. I will be as quick as possible due to the time constraints. Okay, so what is Mimark? Mimark is a company which aims to reshape gynecological diagnostics. Basically, our mission, we envision that there is a gynecological fluid that is contained within the gynecological tract, and this fluid can be the next liquid biopsy for the development of accurate and accessible diagnostics in gynecology. This is not a rare image when you are going into the gynecological consultancy, and sorry for the impact of this image, but it's true. I mean, invasive diagnostic is our routine in gynecological consultancies, and this has been neglected for years. This has been taken as a common procedure. This is just a hysteroscopy, and this is the normal procedure for an endometrial cancer diagnostic process. And I'm talking about endometrial cancers because in Mimark, our first product is dedicated to improve diagnosis of this disease, of endometrial cancer. And I just want to give you like few highlights of this type of cancer. So endometrial cancer is the first most common gynecological cancer in high-income countries, which if you go into the list of the 10 most common cancers in women is the 4th one. and its incidence is expected to increase by 2040 46%. This is due to the association of this cancer with risk factors like obesity and diabetes and estrogen exposure, which is in our normal basis. No, what is driving the diagnostic of this cancer is the presence of a symptom, which is an abnormal uterine bleeding. So women that normally are postmenopausal women have a bleeding that is unexpected, so they attend to the gynecologist, but this symptom is very nonspecific. So we have estimated that there are like around 35 million women every year having this symptom, and only 5% will have cancer. But that means that all of them will have to undergo the same procedure in order to discard the malignancy. The procedure is that women with a bleeding go to the first consultancy, and in there the gynecologist is able to obtain a minimal invasive sampling of the endometrium, which a very thin cannula just in the consultancy without any sedation or anesthesia, and obtain a sample that a pathologist will look under a microscope. So the diagnosis is based on the observation of cells in this type of sample, but in 30% of cases, which is quite significant, there are no cells. And if there are no cells, there is no diagnosis. But still, these patients need to have a diagnosis, so what they have to undergo is then an invasive procedure that needs sedation, that is associated to potential complications, to pain and discomfort, to length, to a long delay into the diagnostic result, and obviously all of this with additional cost in order to get a final diagnosis of their abnormal vaginal bleeding. So thinking about this unmet clinical need with our gynecologists at Vallebrón Hospital, what we did is, okay, so let's understand what is this sample that you are taking that is minimally invasive. And this sample basically just collects all the secretions that are contained within the uterus. So just the secretions per itself, which include the cells, but also the fluid part, when we analyze them at the molecular level, and this is the graph, you could see that really they are like mimicking what we observe in the tissue. So you have the y-axis is the primary tumor compared to this aspirate that we call it of the uterus. So basically you have a sample that it's 100% or almost 100% what you will check with a tissue biopsy if we go for molecular analysis. So this is the foundation of what we have developed. This is WOMEC, which is the first IBD to aid in the endometrial cancer diagnosis. And what is WOMEC? So WOMEC is just an immunoassay test that measures 3 protein biomarkers in the uterine fluid, and that provides a high sensitivity to rule out endometrial cancer out of the diagnostic process. What we are expecting is to reach a 97%, well, I've tried to put this, but doesn't work, so I'll go back. And then what we are aiming to reach for this, the intended use is 97% of target sensitivity. Our data in mass spectrometry tell us that we are already able to get a 99% of sensitivity, so we are confident to move this forward. And with this data, how we envision the diagnostic process. So we envision that in the first consultancy, the patient can get this minimal invasive sampling, and with this sample, that is the PPL biopsy, pathologists can still do their work and check the cells, but also clinical labs can check on the fluid and see these biomarkers. So what is the conclusion of that? That it's just in the first consultancy, and by minimal invasive means you have an almost 100% of diagnosis without the need of hysteroscopy. So we reduce drastically the need to only 3%, we have calculated. And how has been our development? Which are the milestones until today? So before 2021, we had all the research in academia, 4 clinical studies accumulating 350 patients that provide us with our peer review publications and 2 patents. We participated in the EAT wildcard program in 2020, and we won the contest. So we got like 1.5 million in order to spin off a company, which is Merck. And then in that moment, we perform all the negotiations and do the technology transfer. So the company has growing a lot since that time. So on the first years, we dedicated mostly to technology to assess that our biomarkers in mass spectrometry can reliably be determined in an immunoassay, so this technology transfer, and then start to construct during the following years, 2023 for 24, this prototype as an immunoassay. So now we have like our first immunoassay version 1 is now released. And then, like from 2023, we start working, well, from the very beginning, I would say we start working a lot in quality. So in trying to deploy the ISO 13485, accumulating people also for doing reimbursement studies, HTAs, to understand which was our business model, working in protection and performing FTO studies, and also with our clinical team working in really creating a very big clinical study. So now we have like 30 hospitals in Spain recruiting samples, so we have accumulated more than 1,500 samples by today. So these allow us to move forward with the development in all the areas of WOMEC, and then we have like some milestones still to be performed in order to, we expect in 2026, move to licensing agreements with IVD companies, since this is our business model, to license the product to different IVD companies. But this is not just what we want to do. Our company is just a multi-product company, since we envision these gynecological fluids to be extended to other uses. So we are expecting to move this into further applications for endometrial cancers, triage tool with envisioning biomarkers in the cervical fluids, to provide information on the tumor for preoperative staging, and also for endometriosis. And this is possible because, as we say, there is a lot of funding that is needed. We have like an important team dedicated. So we are 3 founders: Marina Rigawa, CEO of the company, Antonio Gil as the head of the service in gynecology department, which now is the CMO in the company, and myself as CSO. But then we have constructed the company with business, CFO, CBO, Todd, and Maria as CTO, which comes from Werfern, and 11 people, which is dedicated to all these regulatory, quality, clinical, and technology and scientific innovations. So obviously with advisors, so we are, I think, thanks to IET, international company. We were created in an international environment, and this is what we are expecting to keep being. So our advisors are mostly international from a clinical perspective and from a business perspective. And well, so far I think we are doing quite well, and we have to always be very grateful for all the achievements that have been done so far, and that we expect keep doing. No? But this brings us a lot the responsibility to move forward our dream project. We are currently seeking for advisors. I think this just put it by Marina, just to always remind in which point we are. And I'm very glad to be here. No, so which I think they are the key success that we had as personalized medicine. So the strong academic and clinical research institution, the growing patient awareness and demand for personalized healthcare, advances in data, which allow us to also get a lot of implementation of the clinical history with the data that we are releasing. Access to funding. Funding is fundamental, and EU funding, obviously, it's bigger than national funding. Emerging biotech and medtech startup ecosystem. This links us with a lot of people and allow us for increasing public-private collaborations. Key challenges, I think they have been said, so I will go fast on this. So limited local investment and venture capital for biotech startups, complex regulatory pathways and slow market access, reimbursement challenges, need for a stronger industry academia translational collaborations, and bottleneck to license innovative diagnostics to large IVD companies. And what startups and innovators need, so more funding opportunities, if possible equity-free, simplified and accelerated regulatory pathways, support for market access and reimbursement strategy development, integration of personalized medicine in national healthcare strategies, and incentives for large companies to partner and or in-license new innovations. What PerMed can do for us. provide training and mentorship in very early stages and also in implementation steps, connections with patients and patient association, foster industry connections and joint projects to get this access, to keep facilitating access to funding and EU collaboration networks, and I would say under specific topics as we were discussing early today, supporting translational of innovations from the lab to the clinic, and advocate for regulatory harmonization and reimbursement policies. Thank you.
Thank you very much, Eva. While you approach your seat, maybe I can ask you, maybe to concretize, we are going to start the debate, and we know, I mean, all the possibilities that we have discussed in the previous session, but let's try to be as concrete as possible. So not every time we have the chance to really inform a European initiative, and we have to define the next annual plans of PerMed. So we have here Wolfgang with the ears open, and we have this incredible amount of experts that we want to put your brain to function, not only to do this analysis that you have done, but how can we really help from PerMed to support this change of model, this change of way of working, this kind of collaboration, the data that you need, the different things that you have discussed in concrete. So let's not just talk about, okay, funding, or let's not talk about data integration or public-private partnership, but concretely, what you think you need? And specifically, I will ask you a question is, imagine yourself in maybe 6 years, 10 years from now, 2030, 2035, what should have been the result there of this action, so that we know what to expect to reach. So let's be provocative in that, or say, and let's go. I don't know if you want to start, Eva, and then we continue with the round.
I can start, so I will be very brief. So one of the things that I think we should do as an PerMed is to put compulsory training for those that doesn't have the training. So you say there was summer camps or there was educational programs, but they are not compulsory to be done, and I think this is needed. So I've been participated in Kaizen pools, in Wildcard, and normally PIs don't have time, and they are interested in doing personalized medicine, but they don't have time, so they might delegate even into other people to do these kind of formations that you offer. But then I think it's important that they do it, so that the coordinator and principal investigators, they are engaged in education as well, and that they are kind of obliged within the responsibilities of having an PerMed project. This is one. The other, I don't remember. I will go back.
I'll come back to you in a moment. I think, Monse, you had also an idea?
Yes, thank you. And I like this question very much, because I like to think that we are collaborating at several levels. And so PerMed, as it is now, or it might be helping or supporting in 5 years. So again, this definition of the strategic agenda, I think this is very important. Many of us have been following the definition of the previous one, and I like to see it redefined with more patients, with, you mentioned that, Wolfgang, policymakers, identifying how to make these policymakers to change the mindset as well. Coordinating with other initiatives like ours, for example, and that's for sure. Launching calls, filling gaps, and you're doing that, but also implement, I mean, this challenge that you have in PerMed of implementation in the health systems, that we succeed with the challenges that we share. I like to see that. Supporting the definition of the value chain, so identifying where and how to support the innovators and the different initiatives. Piloting successful initiatives, and you said that you want to see 5, at least. Let's see that. And then involving these regional authorities in driving this cultural change, supporting the understanding of what personalized medicine can do for the healthcare and for the people.
You have quite a long list for the
I'm very optimistic
Christmas.
about that.
That's good. Okay, Eva, you're back to you.
Yeah, sorry, I remember. So I was thinking also that in order to move these projects into a reality, I would ask if it's possible to put these projects in front of the industry or in front of potential licensors so that you get these connections into a reality implemented innovation.
First of all, thank you for your ideas. That's wishing list now. In general, I would say, first of all, there's other partnerships like for rare diseases. I've forgotten that before. The other thing is actually, and I have to, usually I say the researchers should also have their head up and look into the future. On the other hand, we have to be careful because we expect as funders, but also as industry, maybe too much of them. So we have to find a balance between, let's say, do they really want to do an innovation in the end? I mean, that's maybe, and I don't think we can maybe push a bit more, but I don't think we can do it compulsory that they join these meetings. Nevertheless, we will support them wherever possible, that they have already from the beginning, not only the patient perspective, but for example, there's now, I don't know if you're aware of that, IHI, Innovative Health Initiative, and EMA, they did put a 17-pager what researchers, when they start the project, should have in mind, at least consider, when it comes to later regulatory approval. So these things are extremely important. So they can be a guidance, and we are planning things like that as well. But when it comes to the, first of all, to the private sector, I think we cannot kind of marry them already before they have success. And I think to marry, you need two who really want. And that's the other thing. We can do something like a mentorship, but that's tricky because you have to actually find them, and they have to be dedicated. If you have ideas to kind of boomerang this question back, how we can do that, and beside the matchmaking and partnering events, which are kind of an offer, that's the other thing. And again, when it comes to implementation, and that's the problem. I learned that when you look at other partnerships which are not in the health cluster, it's much easier because you do a product, you get it certified, and you put it in the market. But it's not in health. You have 2-3 more steps before you can say it's successful and helps and makes profit. So that's a bit tricky. And we also have all these ELSA aspects. I mean, Carlos did a nice event for researchers on these topics, and also you have the scientific integrity. So that's when I said you have to make sure that all the results are really, you can recook when you're a private partner. So you see what I mean? We will focus on that, we will support, but it's more with like open hands and offers than with like you have to do whatever you do. Last thing, and that's important, already now, I mean, we are not starting from scratch. There is something called International Consortium for Personalized Medicine, PerMed. That's actually our that's our collaboration arm for international outreach for policy and strategy, because all of the members are funders and ministries and beyond Europe. And then we have also the ERA PerMed, to just call these two, which has been ERANet co-fund, which is also a public partnership. There's 111 consortia with almost 600 research groups funded, and I mean, you might know about that. There you go. So this is not from scratch, and it takes a long time, and we give a lot of offers to these, and also the upcoming PerMed funded consortia. And we also try to already open their eyes when it comes to the other things. And the very last thing, a lot of the consortia applying for these, either successfully or non-successful, they had already the kind of circle which helped them to apply for EC grants, and some of them successfully. And that's the last thing. The Commission is already having this personalized medicine cosmos since 15 years on their map. And I think they do a really good job in supporting this. And that is policy. And I stop here.
Okay, let's, continue with this discussion on public-private approach. Do you have any more concrete suggestion? Maybe, I don't know if Cristina or Roque, you want to talk about that.
Three things. The first one is if the industry wants to find you, they will find you. What the industry in general is doing now is diminishing the risk. So they want the products or the tools or whatever more mature as possible, and then they go and buy them. They want to reduce the risk and increase the benefits. That's the way they proceed. But still, if they want to find you, if they are looking for you, they will find you. And the second thing is, and maybe this, it's something that I asked to the PerMed, which is, so Europe is talking about strategic autonomy, open strategic autonomy. They want to invest more in European manufacturing, clinical development. They want to attract clinical development here and all this stuff. So why don't the public health systems, they are not more open to clinical validation for these people? We have very strong, robust health systems in Europe, different among them, but with difference among them, but they are still very good, and they can be open to this type of people to recruit people, validate, clinically validate all these devices, and this is innovation made in Europe. I think from the private side you can expect a little bit what you can expect, but from the public side we should be more ambitious and ask them to be more open and more helpful to this type of innovation made in Europe. So I would ask you to push a little bit in that sense.
Maybe there's more people joining us today who can comment on that, but first of all, one of the tricky bits is that actually when it comes to health and healthcare systems, the European Commission has no really hand on it, compared, for example, to the research arena. So, because I don't know why, but most of the countries, and if it's in regional healthcare systems, they're very protective. The reason for that is mainly because they don't want that somebody's kind of fiddling around with their total budget. You see what I mean? If there's a pressure coming up that there's more personalized medicine into either regional or national healthcare systems, the usual first expectation is it's too expensive, which is a bit tricky. So then you have to have people who explain to the healthcare system what is the benefit, what is the value. That's another thing I didn't mention before, because it's not only cost benefit, cost effectiveness, it's value. And when you talk about value, it's more than what you need to do the actual diagnosis, and sometimes even diagnosis is not part of that. You do the treatment, and what would that be compared to the usual treatment? But it's more. It's you have all these side effects. You have non-responders. You have the people, if they are young and still working, they don't work for that time. So if you talk about value, it's not only for the person and not only for the treatment, but it's for the society as well. So I think that this is the biggest piece of wood you have to drill, because it's getting more complex if you want to do it in a fair way. But then again, I think the major problem is that everybody is protective of their healthcare system. It doesn't matter on what level. Because they are afraid that they have to spend money for things they don't decide. And I think that's more something, and that's the last thing. That's also why we are so keen and hopefully successful. And also you have your project, Precise EU, that we have regions on board, where we have some regions where they have healthcare systems in the region. And I think they have less budget in total, but they have more flexibility. And there's a reason why the one in Catalonia is very successful in these things. Because there's a closer communication, and there can be easily explained that there's added value when you take these things on board. Sorry.
It's okay, but for example, in Catalonia, we discussed this some years ago. At the regional level or even at the national level, if you have people in our country, I understand that the European Commission cannot maybe be responsible for this, but they can push the member states for this. But for example, imagine in Spain or in a region anyway, they decide that the innovation that is produced in the country, we're going to help them, and maybe we can do an agreement. So this innovation, we can use this innovation and pay less because we pay with offering clinical validation. So this is a way to attract innovation and development of innovation in Europe and in the member states, helping these people which at the end are producing the employees, the richness or the wealthness of the states, and to do products like her product sustainable for our systems. So I think this is something we should try to push for.
Sorry. That is actually an economic perspective which is not directly related to the healthcare system. And there's also, that was in the first roundtable we had in Belgium, that you need the workforce and you need new types of jobs. And that's a perspective even beyond that. And also this is usually not covered when they think about these things. But sorry.
Yeah. So it's clearly that the clinical validation is a huge step in the innovation pathway, and the European funds can help to the risks that face, and maybe after that there is a more willingness to invest from the private sector. So, Roque, please.
Yeah, I think that when we talk about public-private partnerships, we often forget one of the key elements, that are the technology transfer offices from the hospitals. The healthcare systems, all the hospitals have their own technology transfer office, and in many cases these TTOs are underfinanced, with less professionals than expected, and this is also related with something that Carmen said, that in the case of Spain specifically, for the healthcare system you need new professional profiles, because at the end we are seeing with the AIs, data analysts, and many topics in which you really need some kind of technology transfer that links the researcher with the hospitals and the private companies, and at the same time new professional skills that have to appear in the hospitals.
Okay, can I challenge a bit that question? I'm a bit worried sometimes that we use the project money to fund people that should be part of the system, because we are kind of hiding the problem and not facing the reality that these kind of profiles need to be part of the healthcare system, and they should not be funded by this punctual or project approach.
Yeah, but at the end, there could be some kind of obligation of having, let's say, within the hospital or wherever, or the public care system, to have at least, let's say, 5 people involved in whatever. So just with the writing of any kind of call, you can specify some kind of requirement that makes the people that are in the hospital and the people that is writing the call to say, okay, let's check, do we have this kind of people? Do we have this kind of knowledge? Do we have this kind of positions within? Because for this call we need this. And why is the reason? The reason is that if you had those positions, you will much more able to go from the public to the private area.
Thank you. Maybe Raquel, and then I will go to Luis and to Ines, because I think we haven't heard you yet. So let's go with the round.
I would like to comment that, for instance, in some institutions in Portugal, some medical schools, they are actually updating their curriculum, their structure, actually to encompass these new challenges and these new needs, these medical specialties that we need to actually be able to face these new challenges and to actually cross this barrier of not having, for instance, medical geneticists and so on. So these might be something to synergize, for instance, with educational programs. So just to give the idea that we are actually moving forward, but we need more of these and across all the medical schools.
Thank you. We'll contact you to get the references. Thank you. Maybe Luis?
Yeah, thank you. I totally agree with what Rogue said a while. If you put a requirement to be associated in your application to have some of the specialized human resources, that will improve the status of many center research. I would like just to highlight one thing. I love the presentation of this Unmet project. I love it. It goes directly what I said at the beginning. We need to do more precise medicine, more personalized medicine on early diagnosis, because this is fundamental. The society understands that. The society is in favor of that, and we need to listen more to the patients and society. We have to get out from the circle that only the researchers know the questions that need to be answered. Okay? When I'm talking more and more, I have more than 30 years of experience in oncology. When I'm talking with my patients, I'm discovering questions that I never thought about. Okay? And now the question is that the question that a private company will be interested to solve? Do we have the tools to solve that or not? This is another subject, but we need to open the circle of the questions to the society and to the patients. This is first one. The second one is we need to tackle more earlier diagnosis. I'm sorry, I'm not against prevention, but I think to do prevention, we have to change all the economy in the Western society. This will be very, very difficult, okay? We can do prevention in some diseases, but most of our diseases are our style of living as we have right now. It will be very difficult, okay? But early diagnosis is different, particularly for very difficult diseases. And the second one is to change the mindset of the institutions. You were saying, Wolfgang, that probably the public institutions don't want to be open to projects on personalized medicine because of the budgets, okay? That could happen. But for instance, I saw a revolution in the mindset of the CEO of my hospital when we participate on this BRIGHT project for, personalized risk for breast cancer. He was so happy that he decided to apply the money to high specialized people in some areas, creating TTOs and so on. So I mean, we have to change the mindset of some of the CEOs in the public hospitals, of course, by giving them the right experience. And the right experience is to participate in some of these projects that they will see they are not going to expend more money. And particularly if you take on the early diagnosis, they're not going to spend more money. It's not buying drugs to treat patients. You see what I mean? So and I think this will be the open door to change the mentality of many of the CEOs on the public system. That's my opinion.
Thank you. Thank you for this reference on the good practice. Astrid?
Yes, so on this note, actually, I think, again, going back to the policymakers and decision makers, which are frequently the CFOs of hospitals, and this is a very good example. So what I think PerMed could do to support bringing awareness to that level of decision makers is to promote sort of educational or discussion forum that would bring in this level of policymakers. I remember that PerMed a few years ago organized a European meeting with end users. And that I think was very successful and interesting for both parts, both for PerMed and the organizers, and also the commission, and also to the end users, because it was the first time that, insurance companies, for instance, and other levels of decision makers were together discussing the usefulness and of personalized approaches. So this is something that maybe EP-PerMed could do, is to promote meetings at several levels, also at the higher sphere of political decision-making. Because if ministries of health talk to each other, but they don't talk to they don't necessarily always listen to whoever is doing the work on the ground. But if they understand that there are personalized medicine programs that are successful in different European countries, maybe they will listen and try to promote that in their own country. So I think EP-PerMed could help in doing that. And doing that in a more, in promoting a more uniform Europe in terms of awareness of the policymakers and the political level, and also the decision makers in general. And the other thing that might be interesting that I don't see, there is a lot of material and a lot of educational material for patients and for citizens, but it's all spread out in different places. And I think it's, from what I hear from patients, for instance, in patient fora and through focus groups that we have been carrying out in different projects, they feel that, they never know if they can trust the origin of the information. So that would be another aspect that maybe could be addressed in a more uniform way through through EP-PerMed. Having some of those meetings and, to develop something like a campaign that would be coming from a reputable and a trustworthy entity to educate patients and citizens on what personalized medicine means. But doing that not in almost in small groups or in siloed ways, but doing that in a general way for the whole of Europe, and maybe in different languages, obviously. But I think that might be something that EP-PerMed could think about.
Thank you, Astrid. So noted awareness and education and meeting possibilities for decision makers and helping the education for citizens. And so I don't know if you know, I mean, there's a podcast that has been also supported by EP-PerMed. Maybe, I mean, we need to have this kind of more innovative ways also reaching the population, probably.
Yes, and spread out the word.
Good. Can I go to you so that we also listen from you what you think EP-PerMed can help from this patient perspective?
Yes, thank you so much. Hello, everyone. I send my compliments to all of you. Well, I have been listening to the discussion and adding on, especially on what Astrid has just mentioned. I think that I think that an interesting intervention would be, for instance, to have policy briefs with policy decisions, and policy dialogues also. So having some experts bringing information directly to decision makers on personalized medicine. I think it would be very useful at the ministry level to alert to the importance and the need to promote personalized medicine. And this is one intervention that I would propose and this can be done either at the ministry level, but also at the health administration's level. So I think you can think about that. And I also think that at the patient level, that the idea that Astrid brought about having a sort of a platform on personalized medicine where where patients can access materials and information would be quite helpful for patients. But I also think that I don't know, probably bringing also more awareness to more common media. So, for instance, having some interventions in dedicated channels, looking at the benefits of using personalized medicine, what has been done in our country, and so on and so forth. So I think that could be two good options to bring awareness for the patient level. And also, I was thinking about looking a little bit, and now I'm going to comment on the previous session. I'm sorry for that, but looking a little bit at the challenges that personalized medicine might face. I think that we need to tackle a little bit the regional fragmentation that might occur. So we might have better responses or more, at least more visible responses at this level in central hospitals or hospitals within urban areas. And I think that we should think on how to expand this offer also to more underserved areas or rural areas. So I think that is a challenge that also needs to be taking into account. And on the other side, and also regarding this issue about the patients, I think that many health professionals still don't know what is personalized medicine and what it can help patients, and how it can help patients. So I really think that besides working with patients, besides working with decision makers, working also with health professionals, bringing awareness, not only, I know that some of you already mentioned the educational level, so bringing personalized medicine to the curricula of health professionals, but I would challenge you to advance a little bit further and to bring that awareness to those who are already in the field in a more, I don't know, structured way, more consistent way. So they can also advocate for it in the health institutions. So basically, these are my comments. Thank you.
Thank you, Ines. So we are 2 minutes to 5 o'clock. I think we will need to wrap up and close. I find it interesting that nobody has explicitly mentioned funding or money, because I think it's in the end, I mean, it's not the solution only money. It's all what you have spoken about: education, policy level awareness, collaboration. This is where, I mean, of course that requires money. I mean, we are not that naive, but I think it's very good what you have provided. So I will give just a word, 1 minute to Wolfgang, 1 minute, so that you can give a final message, and I will close the session in a minute. Yeah.
Yeah, I'm sorry, I have to say that we have the patients in our focus. We also have the end users in the focus. There's something called the reverse technology transfer, although you have to define end users first. It's not only patients. And last but not least, if you do provide the patient forum, we have to be as funders careful, because we are not doctors. We are not experts in any kind of disease, so we have to be aware. But we have also video awards where researchers explain what they are doing. We have planned a podcast for the public as well, explaining personalized medicine in a general way. So I stop here. I have only a minute, but in general, a lot of your things we have already in the back of our mind, or preparing things. I think it's important that we take patients serious. We don't promise too much. I think that was one of the problems of personalized medicine in the beginning, and maybe misunderstanding. But I think it's the medicine of the future, and we should try together to shape this, that it's not going in the wrong direction. and that it's really for the benefit of the people and not exploding our healthcare systems. So we have to find the balance here. Yeah, I think research is maybe not the biggest challenge anymore. Nevertheless, there has to be done a lot. And I really hope in 5 years I can say we have 5 PM approaches established in wherever healthcare system. Then I would be happy. And again, as I said in the beginning, or some minutes ago, if you are interested in supporting us in preparing the next TRIA, you're more than welcome. We come back to you. With some of you, we are anyway in contact in one or the other way. And there's lots of European funded projects for personalized medicine on the way or just started. So we try also to keep up with their development. So thank you very much. I think Portugal and Spain are already very good positioned when it comes to personalized medicine. Doesn't mean that we all together have to do still a lot to get the full potential out of this idea.
So from my side, I just want to give a big thanks to all the panelists. Thanks really a lot for being here until this time, and also for generosity in sharing your knowledge with that, and also for validating our hypothesis and way of working. I've learned a lot. I hope the audience online also has done it. And I want also to thank the technical team for arranging all the event. And in terms of follow-up, if you have other things that you want to communicate with us, please follow offline via email so you have the questions. We will collect all that in a report that we'll show to you. You can follow us on the website and social media, and you will see the results of this roundtable. So thank you very much, and enjoy the rest of the afternoon. Thanks a lot.
Thank you. Bye-bye.
Wolfgang, please share the slides. Thank you.
Thank you. Bye.
Bye-bye.